Hello, I'm Dr. Richard Powers. This 10-part series is designed to provide you with basic knowledge and understanding of neuropsychiatric disorders in older individuals. Most of this series is going to focus on what we refer to as the 3 Ds of mental illness in older people: depression, delirium, and dementia. There'll be extensive discussions about cognitive loss in older persons, what causes it, psychiatric problems associated with dementia, and other types of dementia besides Alzheimer's disease. However, to understand depression, delirium, and dementia in older people, you first of all have to understand what is normal aging. So today we're going to be discussing a topic that we describe as understanding the aging mind. The objectives for this talk include, first of all, to explain the demographics of aging in the United States today, understand healthcare utilization in the United States, especially of older people, describe basic components of a successful aging program so that you can promote wellness in your elders, and then talk about ways to prevent dementia in older individuals. The reality is that probably the best form of treatment for dementia is to prevent it from ever happening in the first place. Let's begin by understanding the population in our country and why dementia is such an important issue. In this first graphic, what you see is what we refer to as the aging pyramid, where the numbers at the bottom represent younger people and the numbers at the top represent older people. The first pyramid is from 1900, when there were lots of young people and not so many old people. By the year 1970, the pyramid was starting to flatten out a little bit. And at the very bottom, you can see this bulge. That's the baby boomers. The next graphic represents 1995, where this pyramid is actually turning into a cylinder. And by the year 2030, where more people will be over the age of 65 than under the age of 18, you can see that the pyramid is no longer a pyramid at all, but rather it's a true cylinder, and that this bulge, which is at the top, are the baby boomers. Let's begin by defining what is old. In the old days, it was thought that you were old if you were 65 or over. Why is it that we arrived at the age of 65? Well, it doesn't really have to do with physiology. It turns out that the age 65 was arrived at because when Franklin Delano Roosevelt was setting up Social Security, he used the retirement age of 65 because that was the same retirement age that was used in Europe. And it turned out that the European retirement age dated back about 100 years to a system where they allowed you to retire when you were 65 because no one lived to be 65. In fact, 65 has little to do with aging these days, except as a starting point for Social Security. In fact, you really don't become old until you're between 75 and 85. And then, after 85, you're truly old. In fact, we refer to those individuals as the old. Many people who are 65 or 67 are still physiologically quite healthy and quite vigorous. Remember, aging is not a matter of chronology, it is a matter of biology. Now let's turn our attention to the baby boomers, that bulge that's going to be at the top of the pyramid by the year 2030. Who are these individuals? Well, first of all, it's all those folks who were born between 46 and 64. It's 1/3 of all Americans. This is a large demographic group. What do we know about baby boomers? Well, first of all, about 1/4 of them have no children, and about 1/4 of them have one child. That's a very important fact when you start talking about caregivers. We know that baby boomers are low saving, high spending, poor retirement planning, high expectation individuals. These individuals are not like the previous generation who were willing to just get by with what they had. They're not going to tolerate Toyota or Honda services when they reach 65. They're going to want BMW and Mercedes services. So what we're talking about is a large group of individuals who are approaching retirement age at 65, who haven't done exactly a great job of preparing for it, and who have very high expectations for their retirement years. In addition to that, if you look at the boomers, Half of their marriages ended in divorce, and 80% of these folks remarried. Let's think about the caregiver system with these facts in mind. If these boomers have one child or no child, and half of their marriages ended in divorce, and 80% of these folks remarried, which means that one child may be by a previous marriage. And in most instances, the families are no longer living together, so that means that that adult child is living in California or New York. Do we really believe that a stepchild is going to come all the way from New York or California to take care of their stepmother who's living in Alabama? I don't think so. And that's going to require us to come up with a health care system which takes into account that many of these aging baby boomers are not going to have children available to function as caregivers, because 70% of all care in the United States for elders is provided by families. Most of it is done at home, and in most instances the family pays for it. It is not the federal government who is taking care of our older citizens. It is the family caregiver. In fact, most of these individuals are spouses or middle-aged daughters. Many of them are employed and have families. They're referred to as the sandwich generation. This is a 45 or 50-year-old woman who's just on the verge of having her teenage children out the front door when her parents are coming in the back door. That's why they're referred to as the sandwich generation. These individuals are providing the bulk of caregiving in the United States. And as the number of family caregivers diminishes, as the size of the families shrink, we're going to have a health care system that provides either institutional care or in-home care by third-party agencies. The next thing is, let's talk a little bit about these old individuals. The over 85 demographic group is the single fastest growing group in our country. By the year 2020, if you use low mortality projections, which are perfectly reasonable, there will be 8.6 million people over the age of 85. By the year 2040, there'll be almost 18 million people over the age of 85. What do we know about these individuals? As seen in the next slide, these are folks that are going to need a lot of assistance. Many of them are going to need assistance at home, and many of them are going to wind up requiring nursing home care in the long run. So the need for in-home and nursing home care is going to go up as this group of people over the age of 85 rapidly expands. We also know about the oldest old, these folks over the age of 85, that many of them are widowed, are female, and are still residing in their community. Many of them have incomes that are less than $10,000. They will have poor functional mobility, and in many instances they will have mild cognitive impairment. We know that 10% of people over the age of 65 are going to have dementia. Dementia is the loss of multiple intellectual functions by diseases such as Alzheimer's disease. However, when you start looking at those individuals over the age of 85, 47% of them are going to be demented. So therefore, when we talk about a rapid expansion of these individuals over the age of 85, we're talking about individuals without a lot of caregiver support, without a lot of financial support, but in whom there's going to be high rates of intellectual disability. Are they all going to be living in nursing homes? No. It turns out that only 5% of people over the age of 65 live in nursing homes, and that the average age of a nursing home resident is actually pretty old. It's 80 or older. 60% of this nursing home care is paid by family, and by the way, that's quite expensive. So consequently, nursing homes are not going to be the answer for our rapidly expanding population age 65 and over. In conclusion, what do we know about older Americans by the year 2030? We know that they're going to be even older, more folks over the age of 85. The longer you live, the frailer you are, the more physical impairments you have. The longer you live, the more health problems that you have. The longer you live, the less money you have, and therefore the fewer financial resources that you have to care for yourself. We know that 1/3 of old people live by themselves. the longer you live, the less likely you are to have family there to take care of you. It stands to reason, the longer you live, the more money from your resources you spend out, and also the more of your friends and your family die off. These are very, very interesting and problematic demographic facts that we're going to have to take into account. Well, that's the bad news. Well, is there anything that we can do to help prevent this scenario? Or is there some way that we can promote successful aging? And the answer to that question is yes. In a recent study looking at 2 large cohorts of older people, one of whom aged successfully and one of whom aged unsuccessfully, scientists found several interesting facts. That the distinction between the successful versus the unsuccessful agers were basic things like no depression, or if you are depressed, get it fixed. Have a network of 5 friends or more, and walk 30 minutes per day. Let's talk a little bit about these ways that a person can age successfully, because these are the kinds of things that you ought to be promoting in your older friends and older patients. First of all, loneliness and depression. We know that people who are lonely have poor health, increased risk for death, and decreased physical performance. We know that individuals who are depressed have higher rates of heart attack, higher rates of death from heart attack, higher rates of stroke, and higher rates of disability or death from stroke. We know that people who are depressed have higher rates of loss of intellectual function. So consequently, loneliness and depression, and by the way, depression is easily treated. We're going to talk about it in later segments. 90% of depressed elders will get better if you just fix their depression with antidepressant medications. So it is possible to combat loneliness and depression with simple pharmacological and social interventions. Exercise. What does exercise have to do with wellness? Well, for instance, we know that in older individuals, if they walk 4 hours per week, that they reduce their risk for hospitalization for coronary artery disease by 1/3. So if we could just get elders out of the house, more active, exercising more, we could have substantial improvement in their health. And also, by the way, their sense of physical well-being. The third thing that we talked about here was 5 friends. Why 5 friends? Well, we know that 5 friends is a sign that a person is intellectually and socially connected. We also know that individuals who have sustained lifetime intellectual achievement, that is, people who continue to learn even into their latter years, probably have less of a risk for developing dementia. Your brain is a use it or lose it type of organ. You have to stimulate it all the time. So consequently, for those elderly individuals who are stimulating their brain by keeping social activities up, by going to church, playing contract bridge, doing crossword puzzles, those individuals probably are going to maintain their psychological and intellectual fitness. Treating depression, exercising, stimulating your brains through social contacts, those are 3 things that predict successful aging. But there are other things that elders need to do in order to maintain wellness. And one of them is that they need to be thoughtful, careful consumers of health care. In the next graphic we see that elderly population consumes about 25% of prescriptions, occupy about 40% of hospital beds, and consume 1/3 of all health care expenditures in the United States. The elderly person is a big health care consumer. That person also needs to be a careful health care consumer, and here's why. If you look at older persons receiving inappropriate medications, we know that 10% of homebound elders are receiving at least one over-the-counter or prescription medication that they shouldn't ought to be getting. These numbers increase in other studies to as high as 25% of community-dwelling elders. And when we look at nursing home populations, the numbers run between 12 and 40% receiving one or several drugs that there is no real reason why they ought to be getting it. When you start looking at inappropriate prescriptions for homebound elders, we know that 10% of them are getting a medicine that they shouldn't be getting, and that at least 40% of these individuals are receiving one drug that's probably wrong, and 10% of these individuals are receiving several drugs that are probably wrong. One of the drugs that older people frequently get are tranquilizers, referred to as benzodiazepines. And if you look at benzodiazepine prescription in homebound elders, we see that many of them, almost half, have at least one prescription for nerves or sleep. Almost 10% of them have multiple prescriptions, and about 13% of them are getting drugs that are wrong based on the records that were reviewed. What's the take-home message from this? Many elderly patients are receiving drugs that they either don't need or are inappropriate. The reason that this is so important is that if you look at hospitalizations for what are referred to as ADRs, adverse drug reactions, anywhere between 10 and 20% of hospitalizations for older people have adverse drug reactions as a partial or complete explanation for why that person has landed in the hospital. Older people have to be very wise consumers of health care. They need to ask their doctors, why am I getting this drug? They need to become knowledgeable about these drugs. Likewise, older people have to realize that doctors frequently don't talk to each other. We have in this country what I like to refer to as organ-based medicine, where the older person goes to a cardiologist for their heart disease, and a gastroenterologist for their stomach disease, and a rheumatologist for their joint disease. But none of these doctors are talking to each other. So one doctor may be prescribing a drug, and another doctor may be prescribing a very similar drug, but he doesn't realize that one is prescribing and the other one is re-prescribing. It is the responsibility of the older person to bring all of their drugs to all of their appointments so all of their doctors can see what they're receiving. And then when the older person goes to the pharmacist, it's his responsibility or her responsibility to ask the pharmacist whether or not the drugs are interacting and know the side effects of those medications. They have to be informed consumers, otherwise they'll wind up getting medications that they either don't need or that are going to cause problems for them in the long run. Why are drugs so important in older persons? Well, first of all, because they're getting a lot of them and they need a substantial number of medications for their different diseases. But the other thing is that drugs are different in older people than they are in younger. In this graphic we see that first of all absorption is either the same or sometimes decreased in older person. Metabolism and how the drug is excreted and processed by the body may be changed because the blood flow to the liver is changed and several enzyme systems are altered as we grow older. Distribution, in other words, where does the drug go, is changed in older persons. Older people have alteration of their fat-lean body ratio. That is, that they tend to accumulate more fatty tissue. And as a result of that, drugs which are stored in fatty tissue hang around for a longer period of time in the older person than the younger person. In addition to that, many drugs are carried in the bloodstream on albumin. Because albumin levels fall in many older persons, the ability of that albumin to pick up the drug is diminished. And so consequently, the blood serum level may go up. And finally, any drug that is cleared by the kidney may be increased in the bloodstream because our kidney filtration rate goes down as we grow older. So consequently, excretion of the drug may be altered. In conclusion then, absorption metabolism, distribution, and excretion can be altered in older individuals. Consequently, prescription for older people is different than in younger people, and physicians, nurses, and other professionals should refer to geriatric prescribing books in order to know whether or not to adjust the dosage. There are other issues as well besides pharmacological changes that need to be kept in mind when we're dealing with older people. First of all, it's important to remember that in addition to over-the-counter preparations and prescription drug consumption, older people also have substantial rates of alcohol abuse. We know, based on studies, that 10% of older people who present with any medical problem to a hospital or a physician also have some component of alcohol abuse. 8% of elders are problem drinkers. Medicare spends more money on alcohol-related problems in elderly persons than Medicare spends on heart attacks in older persons. So keep in mind that that older person may also be drinking on top of all of their prescriptions. Let's then switch to health status of older people. Health problems are common in older people, although this generation is more physically robust and in better shape than previous generations. We know that, for instance, arthritis is present in almost half of all elderly persons. Diabetes is a common disease. Hypertension occurs in almost half of individuals. And again, we need to encourage people to take their antihypertensives. Heart disease is common, present in 1/4 of all elders. In circulation, vessel disease is common. However, despite these statistics, most individuals over the age of 65 are not disabled. In fact, when you ask older people about their health, most, that is 80%, tell you that they're in pretty good health. That's why we want to encourage them to get regular physical activity. There are some organ systems, however, that tend to retain their function, and there are other organ systems that don't retain their function as we grow older. Let's begin by looking at the systems that do seem to retain most of their function. For instance, the cardiovascular system. In the absence of heart attacks or other severe cardiovascular disease, most people retain some exercise tolerance as they grow older. In many instances, it's quite good exercise tolerance. Likewise, the pulmonary system, your lungs, in the absence of smoking, you should continue to have pretty good pulmonary function. Likewise, dental, down the bottom of this list here. The majority of people now over the age of 65 enter their latter life with their teeth intact. That's very important, both from the personal appearance standpoint and also from the nutritional standpoint. Consequently, for instance, we should encourage prophylactic, preventive dental therapy in the older individual. It's not completely clear what happens to organs like the bone marrow and the pancreas. However, again, I want to emphasize the fact that your heart and lungs continue to be quite healthy over the age of 65. Some organ systems, however, are altered with aging, to include the renal system, which is why we're unable to excrete drugs quite as rapidly as we used to after age 65. The gastrointestinal and genitourinary system. In males, the prostate becomes enlarged, and consequently they may develop problems emptying their bladder. In the females, the bladder may begin to become lax, and they may have trouble with incontinence. Incontinence is, both of bowel and bladder, a major problem in people over the age of 65. Gastrointestinal system. As we grow older, our colon tends to empty a little less rapidly, and so consequently, constipation, obstipation, and impaction are common in older patients. That is, unfortunately, why the older persons tend to sometimes be a little preoccupied with their bowel function. It's because their colons don't work quite as well over the age of 65. And of course, reproductive systems are altered as we grow older. Women go through menopause at age 50, and as a result of that, they tend to put on weight. Interestingly enough, there are now studies that indicate that postmenopausal women who have not been replaced for estrogen may be at slightly higher risk for developing Alzheimer's disease. What are some preventable conditions with older persons? Things that you should be encouraging old people to think about to maintain their health. Well, of course, accidents. As we grow older, we become a little bit more unsteady, and older people need to be a little bit more careful about falls. Smoking-related lung disease. It's never too late, and you're never too old to quit smoking. Complications of alcohol consumption. Again, I pointed out the fact that substantial numbers of older people have serious alcohol-related problems, and the complications of alcohol, to include heart disease, liver disease, and brain disease, can be avoided by alcohol cessation. Atherosclerotic heart disease, hardening of the arteries. Lower your blood pressure, increase your exercise, quit smoking, lower your lipids. These are all important things to do even if you're over age 65. Hypertension. It is very, very important for the older person to control their blood pressure. And cerebrovascular disease. Cerebrovascular disease, things like stroke and vascular dementia, are related to hypertension, hardening of the arteries, atherosclerotic heart disease, and other cardiovascular diseases. There are some diseases that are not necessarily preventable, but the older person can improve their status. For instance, diabetes. For the older person who's 65, good diabetic control is very, very important. Arthritis is made worse by lack of exercise. Sensory impairments. Significant numbers of older people have problems with their hearing and their eyesight that can be easily corrected. Severely sensory impaired people who are deaf, becoming deaf, or severely visually impaired have higher rates of accidents and also probably have higher rates of impairment when they develop dementia. It's very important that the older person get their cataracts removed, and that if they are developing other types of visual impairments, such as macular degeneration, they go to a low vision center and get their vision improved to as much as it can be improved. Nothing is worse than being separated from the world because your eyesight is not what it should be. Osteoporosis, although it is not preventable, is improvable by things like medications, calcium supplementation, and exercise. And yes, there are certain types of dementia that are preventable, and there are other types of dementia which you may not be able to avoid, but which you can improve upon, and we'll talk about that in just a little bit. But let me focus on calcium as an example of simple things that older people can do. Vitamins, calcium, mineral supplementation are very important in the older person. For instance, the older person requires about 1,200 milligrams of calcium per day. In the older person, they usually get 700 to 800 milligrams per day, which means that you're in a calcium deficit. What you need to do is take a simple calcium supplement to get yourself up that 500 milligrams a day to make your bones healthy and strong. Why is osteoporosis so terrible in the older people? Because of fractures. If an older woman especially doesn't take her calcium and falls and fractures a vertebrae, a backbone, she's going to have a lot of pain and a lot of disability associated with that. There are a lot of very simple things that the older person can do to age successfully. In fact, there's a book out called Successful Aging. It's been published by the MacArthur Foundation. It's commercially available. Successful Aging was written by two doctors, Drs. Rowe and Kahn, and it has 200 pages of simple, straightforward, low-tech things that older people can do to make sure that they age as successfully as possible. In addition to physical aging, there are neuropsychiatric disabilities that can be avoided in the older person. Delirium, temporary confusion, frequently brought on by inappropriate medications. Earlier we were talking about how many older people receive inappropriate prescriptions for anxiety pills or sleeping pills, referred to as benzodiazepines. They also cause confusion in the older person. Depression is common in older people. It is preventable with antidepressant medications. And certain types of dementia are preventable, and we're going to talk about those in just a little bit. But first, let's talk about brain changes in the older person. Does our brain shrivel up as we grow older? Are we doomed to dementia over the age of 65? The answer is no. When you look at the science associated with aging in the brain, what you realize is, although brain volumes are slightly reduced, 10% or so, as we grow older, there is not massive atrophy of the brain. Because the brain is slightly reduced in volume, the ventricles, the fluid-filled cavity in the brains, are slightly dilated, but not massively dilated. There is some thinning of white matter. There is some loss of brain cells, some neuronal loss in very selected brain regions. Structures like brainstem lose neurons in the locus ceruleus, which makes norepinephrine. That is why patients are more prone to become depressed as they grow older, because those brain cells that make norepinephrine are essential in maintaining mood. We also know that as we grow older, we may begin to lose connections between brain cells referred to as synapses. That's the bad news. The good news is, though, through intellectual stimulation and intellectual activity, we may be able to hold on to those synapses for as long as possible. We also know that there are certain transmitter systems that are diminished as we grow older, especially what are called cholinergic systems, systems that use acetylcholine. That's why older people are exquisitely sensitive to confusion brought on by drugs that have anticholinergic side effects. In fact, the brain changes in the older person are not spectacular. On the left is a brain of a person who's in their mid-50s, and on the right is the brain of a person who's in their mid-80s. As you can see, the brain on the right is slightly diminished in volume, but it is not severely atrophic. In latter segments, where we look at the brains of patients with Alzheimer's disease and other forms of dementia, you're going to realize that there's a significant, conspicuous difference between this sort of age-related volume loss and atrophy. Now, is it normal as we grow older to become demented, to lose our memory? The answer is no. As we grow older, we do have subtle intellectual changes, but they should not impair our daily activity. When an older person begins to have some memory complaints, we will sometimes refer to that as age-associated memory impairment. What is AAMI, or age-associated memory impairment? Well, as we see here on this graphic, it is a decline of cognitive functioning related to speed of processing. We know that a large number of people between the ages of 60 and 80 begin to complain that they do not process information as rapidly as possible. In fact, 3/4 of older people will tell you, hey, I can't learn things as quickly as I used to. It's more common in males than it is in females. However, their memory is not necessarily impaired. It's just that they lack the ability to quickly pick up new information. That should be distinguished from what is referred to as mild cognitive impairment. In fact, there are 4 stages of memory that we can see in older individuals. There is the normal individual who has no complaint, whose testing is normal, and who, if you do brain imaging on them, CAT scans or MRIs, their brains look perfectly normal. Then there is this second group who will say to you things like, oh, I've got trouble with my memory. But when you test them, they turn out to be perfectly normal. It's just that they don't process large volumes of new data. If you look at their brains with a CAT scan or MRI, again, the brain volume is normal. However, there is this third group, what is now referred to as mild cognitive impairment. Individuals with mild cognitive impairment will tell you that they seem to have some trouble with their memory. They don't have problems in any other intellectual domain. In other words, they're still able to use language, they're still able to do complex motor tasks, they recognize everything quite fine. It's just that they'll tell you that they're somewhat forgetful. When you test these individuals, their testing is slightly abnormal, but not severe enough to put them into the demented range. The distinguishing features between age-associated memory impairment and mild cognitive impairment is like this. If I go to the grocery store and my wife gives me 15 things to buy in the grocery store, and I come home with 10 of those things, that's just age-related forgetfulness. On the other hand, if I go with that list to the grocery store and then can't remember why I'm at the grocery store and come home empty-handed, confused, that's indications that I have mild cognitive impairment. If you look at these individuals, you see that sometimes they will actually have shrinkage of a part of the brain called the hippocampus using sophisticated brain imaging technology. This type of shrinkage cannot be seen on standard brain imaging and has to be done using research technology. We think that these patients may be in the earliest phases of dementia, which then brings me to the fourth category, which is dementia. These people may or may not complain of memory problems. When you test them, their testing is clearly abnormal. Oftentimes they have abnormalities in their brain imaging where specific parts of the brain, such as the hippocampus, are shrunken. In conclusion, then, there are 4 different states from the cognitive standpoint that you can find an older person in. They can be completely normal. They can complain of age-related forgetfulness. They may have what's called mild cognitive impairment, or they may have dementia. These distinctions are very important because we know that patients with mild cognitive impairment have higher rates of developing dementia. If, for instance, you look using a scale termed the Clinical Dementia Rating Scale, normal individuals get a score of 0. Patients with mild cognitive impairment also get a 0. Patients with mild Alzheimer's disease have a 0.5, and patients with moderate Alzheimer's disease score up around 1.0. The annual loss of intellectual function for patients with mild cognitive impairment is about 1 point per year on their mini-mental status exam, as opposed to the mild Alzheimer patient who loses about 2.5 points, and the moderate to severely demented patient who's losing about 3.5 points. What's also important is that if you look at this group of patients with mild cognitive impairment, about 12% of them are going to develop dementia each year, as opposed to normal individuals for whom 1 to 2% are going to develop dementia. That means that there's a 6 to 12-fold increased risk for patients with mild cognitive impairment over their normal colleagues for developing dementia. This then raises the possibility that these patients with very mild memory impairment, people who may score in the 23 or 24 range on their mini-mental status examination, may be in the earliest stages of dementia, and if we aggressively treat them with every form of therapy, pharmacological or whatever, to slow or arrest the onset of Alzheimer's disease, we may be able to hold them in this early stage. And that is the major focus of therapeutic intervention right now in the treatment of dementia. Finding these people who are very, very mildly impaired and going after them with everything we can think of to try to get them to hold on to their intellectual function for as long as possible. Understanding then this distinction between individuals who are normal versus normal individuals who complain of forgetfulness versus people who have true mild cognitive impairment is very important, both from the early recognition and the treatment standpoint. That then means that patients who are normal, when we're talking about treating cognitive loss, we want to use preventive interventions such as keeping them intellectually stimulated and connected, avoiding drugs or alcohol that damage the brain. Same thing applies for patients with age-associated memory impairment, as opposed to patients with mild cognitive impairment for whom drugs like Aricept and Exelon may provide some promise with regards to helping them hold on to their intellectual functions for as long as possible. There are other forms of preventable dementia besides Alzheimer's disease, however. And for those individuals with vascular dementia, alcoholic dementia, and traumatic dementia, simple interventions may help prevent the onset of intellectual loss. For vascular dementia, it's take your antihypertensives, take your medicines that control your heart rhythm. For patients with alcoholic dementia, it's real simple. Quit drinking early. And for traumatic dementia, it's simple things like wear your seatbelt, avoid falls. So what are some general principles for preventing intellectual loss in the elderly person? First of all, encourage that older person to maintain good general health. If you don't have a healthy heart, it's hard to maintain a healthy brain. Secondly, sustain intellectual activity. We know that lifetime intellectual achievement lessens the likelihood that you will develop dementia and lessens the likelihood that you will progress rapidly. Promote independence. Dependence and social isolation are bad for older people. Maintain social connections. That social connections, those 5 friends, promote intellectual connectedness. Treat preventable causes of cognitive loss. If a person is taking medications such as pain pills, sleeping pills, and nerve pills that dull their intellectual senses, try to get them off those medications. And then once it's clear that the patient has developed dementia, try to slow its progression and treat the complications resulting from it. In conclusion, then, the basis for successful aging includes physical wellness, regular exercise, going to your doctor, mental health, avoiding loneliness, avoiding depression, and spiritual vitality. Let's talk a little bit about spiritual wellness because that's an important part of a successful aging program. We know that older persons attend church on a fairly frequent basis. In fact, almost half attend church on a weekly basis. We also know that older people participate in church activities. Half participate almost on a weekly basis. Therefore, we know that older people maintain an active church and spiritual life. We also know that older people have better health, more rapid recovery from surgery, less morbidity related to health problems if they maintain an active spiritual life. So if we're going to keep older people healthy, we cannot ignore their spiritual wellness.